Dr. Keith Eaton is the clinical director of the Thoracic Head and Neck Medical Oncology Program at the University of Washington School of Medicine. Dr. Eaton received both his PhD and medical degrees from the University of California, San Diego, and he moved to the Seattle area to complete his internship and residency at the University of Washington and his fellowship in oncology at the University of Washington Fred Hutchinson Cancer Center Research Center. Dr. Eaton was recognized as a 2014 and 2015 top doctor in Seattle Magazine. And in addition to his clinical expertise, Dr. Eaton continues to study the influence of genetic factors in lung cancer. Dr. Eaton is going to give us a very special patient story. Welcome, Keith.
Thanks for the opportunity to speak with you today. I was trying to figure out where I was going to look. That's where I'm going to look. Okay, so as a brief outline of the talk, today I'm going to talk broadly about immunotherapy. I'll go a little light on that because I'm sure you've already heard about that. Generally talk about clinical trials. As you'll see, my story is a personal story, but also a story about clinical trials. And then I will become philosophical and talk a little bit about being a cancer patient. So my path into medicine wasn't direct. From the time I was a child, I was very interested in physics. My hero was Einstein, and you'll hear how that comes into the story later. But as I was a graduate student in physics, I met my wife, and she was a medical student at the time, and I saw what she was doing seemed very interesting. I didn't necessarily think medicine was going to be as interesting as physics, and it was very interesting. And more importantly, it had the ability to impact people. As I studied physics more and more, if you think of knowledge as a tree, I was really out on a very terminal branch that really only a few people are interested in. And so I felt like the impact wasn't going to be that great. And also the ability to touch individuals wasn't really there. It was more isolating. And so I changed into medicine. As Terry talked about, in '98, I moved to Seattle here for my training. And I've stayed on faculty and specializing in lung and head and neck cancer. So this story starts in 2012. At that time, I was a busy medical oncologist working in head and neck cancer. I did teaching and administration. My research is primarily focused in clinical trials of novel agents. At that time, we were still working in trials with conventional cytotoxic drugs, small molecules. I had research interest in PET imaging, and immunotherapy was really just starting to come into the fray in terms of solid tumor. So I talk about this not being just my story. We were participating in clinical trials at the time. There's always been this idea that the body's immune system could be used to fight cancer, and of course bone marrow transplantation is the first example of this, where the graft versus leukemia effect is really one of the key mechanisms by which it works. And this wasn't seen as much in solid tumor, although there was evidence of regression spontaneously of melanoma and renal cell cancers. This led to the development of kind of crude immunotherapeutics, interferon and IL-2, which were very toxic. But the broader use of immunotherapy in solid tumors remained elusive. We had the opportunity to participate in some of the first phase 1 trials of anti-PD-L1 and anti-PD-1 trials, and this was my first New England Journal article. Through our newly opened phase 1 program, we had the opportunity to enroll a lot of patients in this study. And for the first time, this is the non-small cell lung cancer subset, and for the first time we saw responses to immunotherapy in lung cancer patients. And this is a so-called spider plot where you have tumor size on the y-axis and time on the x-axis. And you can see some of those patients' tumors got smaller and stayed small over time. And you can see the responses were durable, and in here lasting up to 80 weeks. But in fact, they can last up to 5 years, that data that was just published. So this is really miraculous. And to me, it was the first idea that, about the power of immunotherapy. Well, I have a family, and at that time, we always had this idea of putting out a holiday card, but it's one of those things that never really comes to pass. I might take the picture, get the cards, but they don't get sent out. And maybe you have the same experience, some of you maybe not. But my life was starting to come together. My kids were growing up a bit. My children had always wanted a pet. We had very much resisted getting a pet because life seemed very chaotic, and I guess we'd reached the point where we thought we could do that. And my wife is very much of a researcher and wanting to optimize everything. She looked through, the various characteristics. I don't know if you ever go online and look for a dog. You can see that, I want to minimize drool and optimize intelligence and shedding and these kind of things. And so it turns out poodle is the best dog for that. Well, a poodle's a very smart dog, and in fact takes a lot of work to raise a poodle puppy. And spoiler alert, I'm going to get cancer in this story. And the dog was the first casualty in this because my wife couldn't take care of both the dog and me. So, like a lot of stories, it begins with a story to trip to grandmother's house. And my grandmother at the time was 90 or 91 years old. This is not me. This is my brother, who looks quite a bit like me. He and I would go to Detroit to visit her once a year. And it was just about when this was going to happen. I had felt poorly the month before. I was still going to work every day, but my performance and things like playing racquetball was deteriorating. I was losing to people I ordinarily won. And I had had a cold and was feeling under the weather. And then I started to develop hip pain, and I said, Reiter syndrome, reactive arthritis. And that was like maybe a Tuesday. And then the Wednesday night, I started getting sternal pain, and I said, that fatigue, sternal pain, marrow-bearing areas, I think I have leukemia. And it was Thursday morning. I was about to go to my grandmother's in Detroit, and I said, if I think I have leukemia, I should not get onto a plane. And so I turned to what I call my work spouse, Dr. Martins, and I said, I think I might have leukemia. Could you order some labs? And he did. And then I'll show you what happened an hour later. This was my CBC. I had a white count of 2.7, which is abnormally low. Platelets of 50, again, abnormally low. I was neutropenic. There were these dreaded unclassified cells, a very high LDH, and a quite elevated D-dimer. So we knew what this meant. We had our little cry. That was really the only time I cried during the course of this. And then we set to work on what we had to do. Within, I don't know if it was that day, or I think it was that day, I had a bone marrow biopsy. And it showed that my marrow was replaced with leukemic cells, 95%, with a phenotype characteristic of B-cell leukemia. And then soon thereafter, this is what my life was like. I was no longer a free-range person. I was confined to my room. And this is the IV that stood next to me with IV fluids, antibiotics, chemotherapy, and blood. And I remained in and out of the hospital for much of the next year. I'll talk later about cancer being a roller coaster. So the nature of having cancer, and especially leukemia, is that you get all this different diagnostic information as you come along. Oh, you've got leukemia, and then we start doing prognostic factors. And you could have good prognostic factors or bad prognostic factors. One of the things we do is count chromosomes, and high is good and low is bad. And so at first it looked good, and then they did further tests, and it looked really bad. This is my first paper that we got out of it, and because it was really a use of a novel technique of what's called CGH to more adequately characterize the phenotype. And you can see there towards the bottom my karyotype. Normal karyotype would be 46XY. You can see all of that crazy stuff there that's going on, meaning that my chromosomal complement in these leukemic cells was highly altered. And so what looked good at first was really quite bad. So The first picture is Dr. Martin's, as I talked about. He was my first visitor and, of course, my first encounter with this. And he came to me and visited me in my room, and he said, Keith, you don't know what new treatments are out there. I know this looks really bad, but you're going to do okay, because there's all sorts of new things on the horizon. And he and I practiced together for a long time, and I know he says that to our lung cancer patients. And I was like, I'm not really sure. I always said to him, I said, is that really a fair thing to say? I didn't really protest too much. I just kind of said, I was tired. And what he, early on in this story, he asked me, so you've got leukemia, tell me who you want to be your doctor, and I will get that person to be your doctor. And when I came in '98, I encountered Dr. Michael Lindenberger, who from the very beginning struck me as the best doctor that I've ever worked with. And I've been very fortunate to have him as my physician. And the next picture you see is someone you'll recognize. He spoke earlier here today, Dr. Applebaum, and he came and visited me in my room as well. And he said something very similar to what Dr. Martin said. And given the fact that he was an expert in ALL, I had more of a tendency to believe him. So I'll tell you more about that later. So I went on to receive standard induction chemotherapy for ALL with a regimen called Hyper-CVAD. It comes in 2 parts. After the first part, it really wasn't looking like it was working at all. And then I got the second part, which worked a little, and my blast went from 95 to 31. You say, oh, that's a third reduction. That is not good for those of you who know about leukemia. You really want to get to undetectable disease. And after a bit more chemotherapy, it had been reduced to 2%. Again, you're like, 2%, that's great. That is not good. You really want to get to 0. And so it was looking very bleak in terms of standard approaches. And my first equation is regarding clinical trials. And clinical trials are equals hope when there's no standard option. So for a lot of people, it's pretty early to tell easy on that the things that we ordinarily do are not going to be helpful. And oftentimes people turn to clinical trials, and of course that's how we make progress in figuring out how to treat cancer patients. Well, the question is, how do you find a clinical trial? Well, I'm sure you all being in the cancer field have had what I call the FOFWC, the friend of a friend with cancer. And you have to look in all these things and figure out, of all the things available, what is there? So if you go into, at the time I wrote this talk, adult ALL, and put in that, and you find that you get 220 trials nationally. How do you pick the winner, if there even is a winner? So it's really helpful to have a physician who understands the landscape and understand what's most promising. In a given cancer, at a given time, there's not always a clearly promising winner, but at this time, the people that I knew and the people that helped care for me actually knew about something that was happening, and that, of course, was CAR T cells. But you can imagine that this is highly dependent on having an expert, and not everyone has access to that. Other aspects that affect clinical trial participation are geography. So if you live in rural Montana, you're not going to have great access to clinical trials. And we see many patients internationally. The financial barriers are great there, and that's often not able to be overcome. There are also insurance issues. There was a question of whether insurance would cover the clinical trial I was at, or whether it would cover the hospital that I was being treated in for that. And then there are just general finance issues. You go from being a fully employed person to being unemployed, which has a significant financial impact, even if you get disability. So what I'm highlighting is there are a lot of inequities. Whether you get treated in an academic or a community center or a comprehensive cancer center makes a big difference in terms of the things that you're offered and your outcomes. So phase 1 clinical trials. Historically, phase 1 clinical trials have been about testing whether or not a drug is toxic and figuring out what a reasonable dose to give to people is. And the response rate has been very poor, 4% in the time period from 91 to 2002. Nowadays, we have a better idea. We're not just kind of throwing poisons at cells and seeing if they die and the host doesn't. there's more an idea of biology driving what we do. And so there's this idea of target matching. So if a patient has a specific driver mutation, we can target that driver mutation. And so with this, the response rate in phase 1 clinical trials has gone from 5% to 27%. So it is a better proposition, but it is still really an experiment. And one of the exciting examples that I had an opportunity to be involved with just as I was coming down with leukemia was this approval of ceritinib in ALK-rearranged non-small cell lung cancer. So this is an example of a targeted therapy that was tested in phase 1 and went directly to be available to patients, an FDA approval out of phase 1, which was truly something that we had never seen before. So again, I talked about that picture that we were going to send out of our family. By the time it was time to send it out, of course, things had changed. And so I actually did manage to send out this to family and friends. You can see I was no longer having hair. I sometimes say, with the CAR T cells, it's like the hair club for men. Nowadays, I'm not just the owner. I'm also a customer, because you'll see later I get to sell the CAR T cells too. I talked about Dr. Applebaum saying there was something else that he was very excited about to potentially treat me. And this was, of course, CAR T cells. At the time, we were at the Hutch, we're working very hard on CAR T cells, but we had nothing in clinical trials. And Dr. Carl June and team, Dr. June is in the center. Dr. June actually started at our institution and then went on working with the DoD in developing CAR T cells actually for treating HIV. But his true interest was in using them to fight cancer. And his program was the most developed at the time at Penn. And he was in close collaboration with colleagues here. And they put me in touch with him, and he called me on he was over here, and he said, "Oh, do you want to come meet me?" I said, "Oh, I'm in the hospital. I can't meet you right now." And he said, "Well, give me a call, and we'll see what we can do." So I later did end up giving him a call. And he was on his cell phone, and he was about to go to ASH to give this talk about their very exciting results with a few patients in childhood ALL. And he says to me, "I'm glad we're talking today, because after today it's really going to be crazy, because there's this New York Times article coming out about this girl who was basically near death, dying from ALL, who was miraculously rescued by the CAR T cells." And this is really the beginning of the hype about CAR T cells. Dr. June proceeded to butt dial me throughout the rest of ASH. And so I get to hear him checking into his hotel, getting off the airplane. It was kind of interesting. So this is something you've already heard. CAR T cells have gone through various evolution in terms of modifying the construct used to create that. The basic principle is that there is a cancer detecting part on the outside that consists of an antibody that recognizes something particular, in this case CD19, which is expressed on most B cells, and then it goes through the cell membrane and to an intracellular domain, which is activating, and those come in different flavors. The general principle, which you've heard already, is that the patient goes for leukapheresis. Actually, before that, you're tested to see if you have adequate number of cells to make the leukapheresis productive. I went to Philadelphia to be leukapheresed. I then returned home. My T cells were transfected and grown in the laboratory, and then I returned for them to be infused. Prior to that, I received lymphodepleting chemotherapy. I'll tell you a little more about that. So the logistics, so you can imagine this was the winter of 2012-13. It's flu season. I'm profoundly immunocompromised. The thought of getting on, and already, I was kind of living my life basically confined to home, not seeing people at all, because I knew, it was impressed upon me, both in my own training and by my doctors, that, getting an infection can really mean the end. And so the idea of getting on a plane in flu season seemed quite daunting, and through the generous donations of many people and organizations, I was able to get a private flight, which was quite exciting, to Philadelphia. But again, this comes to this idea of privilege and accessibility. I mean, it is true that they will do this for, if you get set up with, I think they're called caring angels or something like this. But you have to have the resources to make that happen, and not everybody has that. So as I talked about in February of 2013, my cells were collected. I had to be reinduced because already I had relapsed. During the course of this, I was trying to get in the trial. I was actually the first adult treated with ALL, and the IRB had not yet been completed, and so the optimal time for me passed because the study was not yet open. So I had to be reinduced, and I went into the treatment with 10% blasts, which again, not good, better than 62% where I started this second time. In March of 2013, I had the infusion of CAR T cells. It was quite remarkable. I went to they were starting this out as an outpatient, and I went to the research unit, and you go there, and it was just a little 10 cc syringe had like 1 cc of cells in it. I said, okay. Well, then I went home and then proceeded within the next few days to start having really high fevers. And of course, I had just gotten chemotherapy, and so I came in, and this is one of the markers of inflammation. So these are two markers of inflammation, ferritin and C-reactive protein. In medicine, we oftentimes collect, kind of our best of, who had the highest TSH, who had the highest white count, and so forth. And I was kind of tying or beating my own record for ferritin. So I was excited about that. And this is all part of the cytokine release syndrome, which I became very familiar with. One of the other abnormal vital signs that you see is a very high temperature. And so this is my fever curve over the first week, and you can see the temperature, went over 104. It actually went over that because at some point during my illness, the nurse comes into the room and takes my temperature and said, this one's broken. I get another one. And this one's broken too. I said, that is not the problem. The problem is you're outside the range. And so I continued to have fevers for actually 2 months. I was in the hospital with fevers. I think we're better at this now. But at some point, winding up in the ICU on pressors, and eventually I got tocilizumab, and things became more manageable, but I continued to have fevers for quite a long time. So the good news is that the day 27 marrow showed absolute success. The blasts were undetectable by flow cytometry, and then later this new adaptive assay that uses deep sequencing to look for the abnormal clone and can detect less than a part in a million was also negative. So I had achieved a very deep remission. This is the paper that I am not an author of, but I am a subject in, and that was the result of this research that I was participating in, and was really the first definitive evidence that CAR T cells are effective in leukemia. Now, the results of this, the publication date here is in 2014. The results of this weren't available, as I talked about. I was really the first adult treated on trial. And so what we didn't have was this, which is the survival curve. And even though I'd reached such a great remission, as you can see here, the survival curve drops. And actually, by about, you look there, by about 9 months, half the patients have progressed. And achieving such a deep remission, there's two questions. What do I do now, right? So ordinarily, we would think that would be quite predictive of doing very well. But the issue is that I had chemorefractory disease. If I did relapse, it would be with something that had presumably learned to outsmart the CAR T cells, and there would be no effective therapy. So talking to Dr. June, what should I do, Dr. June? He said, this is going to work great. You don't need anything else. And then coming back and talking to Dr. Applebaum, he said, you need a bone marrow transplant. And I'll talk about that in a moment. So this is the cytokine release syndrome. Part of that paper was one of the things that they saw was that you, depending on how much disease you have going in, you can have a greater cytokine release syndrome. This is, of course, related to how much stimulus there is to expand those cells. And it's, of course, correlated now correlated with IL-6, and that also points to a therapeutic modality, anti-IL-6 treatment in order to manage this cytokine release syndrome. So the conclusions of that paper is that these CAR T cells were highly effective in treating ALL, and that it was associated with a high remission rate even in patients. So the patients on these studies are, of course, all patients like me who had no other options and were highly likely to expect to die because of a lack of other options. And what they did see was that although some people relapse, there are definitely durable remissions. So when I returned to Seattle, everything they did showed that I didn't have any evidence of leukemia. But I don't know if you're familiar with this saying, Maslow's hammer, or the law of the instrument. If the only thing you have is a hammer, everything looks like a nail. And so the Hutch's hammer is bone marrow transplantation. And I was very familiar with this. So I trained our fellowship has changed and is more broad or diverse now. But at the time I trained, I had 13 months of training, 7 of which were bone marrow transplantation. And as a fellow in bone marrow transplantation, you're working mostly in the inpatient and seeing all the people who are doing very poorly. So I didn't have a great opinion of bone marrow transplant. But nonetheless, in thinking about all these things and the logic that I was talking about before, I chose to undergo a transplant. And again, I had the opportunity to participate in a clinical trial, as most of our patients do. But interestingly, this was a trial that was designed by my colleague, Dr. Mitsarek, who I trained with through residency and fellowship. And this was an unusual trial, maybe now not so unusual, but it was aimed at reducing graft versus host disease, and it had the feature of you getting the chemotherapy after you get the stem cells. And the intuitive thing is, like, we were trained, never give chemotherapy after you give stem cells. Well, the conditioning regimen had radiation before, infusion of stem cells, and then high-dose cyclophosphamide, which, as it turns out, does not kill stem cells, but has the potential to wipe out expanding T-cell clones, which mediate graft versus host disease. And the goal of this trial was to reduce graft versus host disease, which is, of course, as I have learned, you can survive leukemia, but live a life that was much worse than dying by suffering from chronic graft versus host disease. And I've had the opportunity to care for some of those patients. And knew to fear this. This is my brother. He is undergoing the leukapheresis procedure to be my donor. And then this is me. Receiving my stem cell transplant, and Pamela's hands there, who's in the audience, was actually giving me those cells. That was my, what do we call that? My cancerversary, or my stem cell birthday. And these are my parents visiting me in my room soon thereafter, when I was kind of recovering from that and through the period of having mucositis. I'll show you this picture later in the talk. It comes up. So having a transplant is a lot of work. I tell my patients cancer is a full-time job, and as a transplant, it's really a full-time job for 2 people, the patient and the caregiver. And this is what breakfast looks like. Their lunch was not quite as big, but dinner was as big. So I reached the 1-year transplant point, and I was continued to be in a complete remission. So a lot, as I was talking about, I participated in a lot of research. This was the study that Dr. Mitsarek and colleagues published based on the study that I participated in. And in this, they reduced the chronic graft versus host disease rate to 16% at 1 year. So they achieved their goals. It was cut down by about half, and so that's, I would say, a truly remarkable achievement. One of the other things that we do is that even if you don't participate in research, if you consent to be followed, every patient at the Hutch is tracked very fastidiously in many different domains, including a lot of surveys. But one of the things we can do is make generalizations that go beyond what we find out in clinical trials. And this is one of the things looking at the effect of having minimal residual disease after transplant and how that affects the ultimate outcome of transplant. And then there are things that are a little more soft. So one of the problems that I did not, leukemia has ALL has the propensity to go to sanctuary sites such as the brain. And these are less well treated by chemotherapy. And so the idea is that you get intrathecal therapy in order to help sterilize those sanctuary sites. Well, I'd had a lot of sterilization in my sanctuary site. Okay, I'd had 10 IT methotrexates and other things, but I developed very severe headaches that were becoming rather debilitating. And then I was coming into transplant, and they said, "We do 6 after transplant." I said, "I cannot take 6 after transplant. I won't be a functional human being anymore." And I went and I reviewed the literature, and the paper they were basing it on was from 1984, and things had changed quite a bit in terms of what we know about leukemia and exactly how much they knew about the risk of the patients and so forth. So based on my read of the literature and working with my doctors, I decided I'm not going to get those. But so afterwards, they actually went and looked back and analyzed all this data and decided that I made the right choice. And I guess history has shown that I have too. So what are the lessons that we can learn from my experience? So one is the risk to benefit ratio is improving in phase 1 clinical trials. It can take a lot of perseverance to get into a trial, especially if it's in a different place or if you're early on in the trial. Delays matter a lot. So when the IRB is delayed and you have a potentially effective therapy, this is hurting patients. That travel is costly and expensive, and there needs to be a lot of facilitation. There's concerns over cost. Consenting for all these trials can be overwhelming. I was talking about, when you're getting a bone marrow transplant, you're actually approached for many clinical trials. So many, in fact, that you don't get a consent form, you get a consent binder. Going through and figuring that out, it can be quite overwhelming. And one of the things is that I'm standing here today because one, I was at the right place at the right time with a wrong with something bad happening to me, but I knew what to do and I had the resources. Unfortunately, this is not, if I were at a different place or had different means, this wouldn't have happened. But the exciting thing is that one person can contribute a lot to our knowledge and the field and make things better for patients in the future. So this was, the product that I received was actually the one that went on to be the first CAR T-cell therapy. I don't know, Kymriah? Let's see if I got that right. And so that was a very exciting thing. I got a call, I think Scott Ramsey set a reporter up with me from USA Today. I got a above the fold article, and you see that picture there that I showed you earlier. And I was interviewed by the reporter and so forth, and they said, "Oh, can you send a picture of you, during your treatment?" I said, "Yeah." And he said, "Well, who are those doctors in the photo?" I said, "Well, those doctors are my parents." So I will shift gears here. Let's see how am I doing. Perfect. This is my more philosophical part, thoughts about being a cancer patient. I told you I would come back to Einstein. So I told you my wife is very much kind of an explainer. She wants to know why everything happened. Was it when you're in the physics lab? Was it the radiation? Was it the chemicals you got here or there? It's like, no, honey, this is just bad luck. And Einstein comes into this because he has a phrase, he was really talking about quantum mechanics. Quantum mechanics was very different from the physics that came before it because it was probabilistic in nature, right? You don't know where something is going to be until you look. And this was very troubling to him, and his saying was, God does not play dice with the universe. And so as it turns out with regards to cancer, a lot of what causes cancer really can be amounting to the equivalent of dice. And that is random variation. So the genetic hits that you get over time to your genome can cause cancer. And this is a paper by Bert Vogelstein, who is one of the true leaders in cancer research of the last century. And looking, and you can see there on the third line from the bottom that it's, oh, that's not what I wanted to do. That it's due to, their conclusion is it's bad luck. And which is, because oftentimes patients ask me, why did I get this? And if the answer is in smoking, it's bad luck. And even if it is smoking, it's still bad luck, since most smokers don't get lung cancer. So I have this metaphor which I used, I think I used it before I got sick, and I certainly use it afterwards, is that life with cancer is a roller coaster. There's bad news, and there's good news, and there's bad news, and there's good news, and that kind of constant up and down can be incredibly taxing. And I think if you go into it ahead of time knowing that, it can help a little bit. I talked a lot about the treatment and the details of treatment. It's really about a lot more than that. So family support is incredibly important. Friends, if you have it, spirituality. And then even without spirituality, one can have what is referred to as a sense of purpose. And one of the most, so I went from being a very busy person to having a lot of free time on my hands, without so much energy perhaps, but still, me at 40% is still a fair amount of energy. And so I used this opportunity to really read a lot and try to understand, to kind of explore intellectual interests that I didn't really have the time to pursue when I was a busy clinician and researcher. And of course, having cancer, I explored things that were kind of more germane to my current situation. And Viktor Frankl's Man's Search for Meaning was one of the most useful things I found. And I continue to find it useful for counseling patients. So for those of you who are not familiar with this book, it's considered to be one of the best books of the last century. It usually makes the top 100 lists. And Viktor Frankl was a psychiatrist and was interred in Auschwitz for 3 years. And despite that, managed, he was kind of the helping person there. And, Man's Search for Meaning it's divided into 2 parts. The first part is really telling his story in the concentration camp. And the second part is really telling his story and his theory, his psychological theory of how does one approach that and how does one approach life. And I can't remember if I read the book this way, but I actually skipped to that part first, and then read the other part second. That's usually the way I read the Holocaust stories. But he came out of this with a philosophy, and the crux of his philosophy is that the main motivation for living is the will to find meaning, and that this is an inalienable thing, right? So even if you're locked up, you can still find meaning. And whether it's locked up by being in a concentration camp or by an illness, that's the case. And so how does one find meaning? And some of these are obvious and some not. So by creating a work or a deed. So all of you presumably are here because you're in healthcare and we're working towards making things better. This is beautiful because it is a thing that's intrinsically aimed at helping people, right? So there you go, you have meaning. Sometimes we have to remind ourselves of this, sometimes not. Working in the cancer space, it's, as Hanato says, he goes, the only thing that would be more would be kids with cancer, and I can't do that. But we are in that way fortunate to have this. By experiencing someone or encountering someone, or a thing or a person. And this is what I call love or appreciation or thankfulness. And then the last one was the one that I didn't understand at first, by the attitude we take to unavoidable suffering. So there's this idea of a certain sort of dignity that you can have with the unavoidable suffering that comes with life. And that was the part that was new to me. And the other thing is that participation in research offers meaning. So we don't usually stress this to our patients, but some of them, they figure it out. And they're like, I don't care, experiment on me, doc, I want to help the next person. And so we see that sometimes. So there's this idea of silver linings, so clearly I've told you about a lot of silver linings that I've had throughout the course of my illness. I talked also about the difficulties in logistics. So Philadelphia is not quite as tight in the housing market as Seattle, but it was pretty bad. And I had this task. I was going to be living there for 2 months. Where am I going to live? I didn't want to be in a hotel room that whole time. And they didn't have, here we have a house or several houses where we put transplant patients or people who are going to be here for a long time. They did not have such a thing. And so I was left to finding a place to stay. And then one of the research coordinators said, there's this place called the Franklin Residences, which was a historic hotel where you could stay. And it really wasn't that special. My room, it was actually quite old and nondescript, but it had a fabulous lobby. That's the lobby of the hotel, or the apartment building. And it was just a tremendous lobby. Well, it turns out that lobby was the lobby used in the Silver Linings playbook. And so I thought that was like reminding me of Silver Linings. The other, I talked about spirituality. I think it can be a very important thing to people. It certainly was to me. I'm Jewish and I was practicing, but as I talked about, I was locked up. I couldn't go to synagogue. And one of the neat things is that at the same time, people's web presence, and this is at the time the chief rabbi of England, Jonathan Sacks, who I think is one of the smartest persons I've ever encountered in my life. He had a website and would write essays every week, and he's the person that helped me find Viktor Frankl. And so I would read these and reflect, and I found a lot of meaning and help with that. And the other thing is that I had a blog. And so there's this huge communication task when you have cancer and you have a community of friends or colleagues or coworkers and everybody wants to know how you're doing. The most boring thing to do is tell your cancer story over again, present accepted. So there are these tools now. The internet has really made things amazing. So there's sites, CaringBridge is the most notable of them. And so you can kind of tell your story, and I had like a paragraph on what would happen to me at the beginning, and then I would post kind of weekly updates or at whatever frequency it was, and I would tell a little about myself, but I would also use that opportunity to share something I learned or a funny video that I saw or something, and people would respond, and it was really great because I felt like I was connected to the outside, even though I couldn't see that, in a physical way. I want to point you to I had 26,000 visits. I'm very proud of that. But one of the cool things is that colleagues that I interacted with very peripherally were just very caring. It also gives people an outlet to express their concern, or which is really nice. And it's not as invasive as like, I want to come see you. That's not what you want when you're a cancer patient. Like, I got to come see you. It's like, no, you don't. I'm happy to hear. It's like you look sick. So I returned to work in July 2014. I continued to do clinical work and clinical research. When I returned to work, I was actually one of the busiest physicians at the SCCA prior to my departure. And when I came back, Dr. Applebaum said, Keith, you're really busy before. I don't know if you're ready for that now. Do you want to think about doing other things? I was offered a number of different opportunities. And the one that I choose to do was become the medical director for quality, safety, and value. And now I work a lot on patient experience and trying to improve things for our patients in a more systemic way. So I close on this thought about miracles. So I often get asked by patients, do you believe in miracles? And one of my things is a miracle depends on how you define miracles, right? Looking in the dictionary, there are two ways that are on the top of the list. So the first is an effect or extraordinary event in the physical world that surpasses all known human or natural powers and is ascribed to a supernatural cause. The second is a wonder or a marvel. So I certainly believe in miracles in that second sense, and I believe that I experienced one myself. And thank you all for your efforts in working to help these miracles happen for others. Thank you. Thanks. So I will entertain questions if you have them. Yes?
You mentioned the IT. Do you feel chemo brain?
I don't know. So the question is, do I feel chemo brain? I also had total body irradiation. So I don't know. I think I'm doing pretty well. I also have sleep apnea, right? And I was diagnosed with that like maybe when I was 35 or 40. And like after I used it, I had an extra hour every day. And I said to myself, gosh, think of how much better I could have been if I had that, a decade earlier. And, you can always have those kind of what ifs. And, like the other thing is like, I actually learned how to study when I was in medical school. And when I was a graduate student in physics, I didn't really study with the same sort of intensity that I did. I was like, how good of a physicist could I have been if I had done that? So I think sometimes, and I think as you get older, you have trouble with the, how many objects can you hold in your memory? I would say that's the biggest thing. I think you learn little workarounds. And how much of that is, of course, some of that must be related to the hits that you take as you go through your life, but I don't know. I'm doing okay. Yes? Well, I was delirious, and so the question is, so the interesting thing about neurotoxicity is it seems to be product dependent, and so the Novartis product seems to have less of it, from what my understanding is. But I think, I certainly was delirious, but I think that would be expected in those circumstances, although it was early on enough that wasn't kind of the top of mind, since, it was much earlier on. But I think it's a little bit product dependent. Anyone else? Yes.
The curve that you showed us,
Mm-hmm.
that's about the relapse rates?
Yes, the survival curves from the.
So were those just adults?
That's. I think that was just an adults paper. Well, I can go back. Let's see. They'll be in the deck, but I think it was.
Would they compare adults and children?
Well, I think.
Fair comparison to
No, it's not fair to compare adults and children. Children always do better than adults. Yeah, but I think that was all adult. I think that was all adults, although I can't swear to that. Okay.
I have a question. So, did you suffer from any graft versus host?
I did. I had both acute and chronic graft versus host disease. The chronic was very low level. It was just a little bit of like a rash on my lip. And in the acute, it was a GI based. So, but, so you had just, I think that's kind of what you want, is just the little.
Yeah.
The littlest bit you can possibly imagine.
And you're still taking meds for that?
No, I got off all immunosuppression before I returned to work, which was in 2014. So.
Yeah.
Yes.
As one of the early immunotherapy patients, do you have anything now that contributes to that as far as like
No. Well, the other thing, so the other aspect of, the nature of what I got, so ordinarily patients who get CAR T cells will have B cell aplasia, at least with some of the products, because it's wiped out all the B cells. When I got my brother's graft, it wiped out the CAR T cell graft. So presumably none of the, there's nothing persisting there. Great. Thank you all.